Just a little heads up that this episode contains themes around eating disorders. So do take care if you're listening, and that might be a sensitive subject for you. Welcome to the Relational Lives podcast. I'm Ali.
And I'm Roz.
And we're both psychotherapists.
This is a podcast about the complexities of relationships and how trauma, attachment, and lived experience shape how we love and connect.
Because relationships are rarely simple, and we want to give you the understanding to unlock your relationship's full potential.
If you enjoy this show, please give us a 5-star review and subscribe on whatever platform you are listening on. This also means you'll get notified when new episodes come out.
And we enjoy engaging with our listeners, so do reach out with your comments, or you can email us at relationallives@gmail.com.
What do you do when the person you love is clearly struggling but insists they're completely fine? Today we have another listener letter, and it comes from a partner who feels stuck in exactly that place, watching someone they love become increasingly controlling with food, while being met with denial every time they try to talk about it. It's confusing, it's painful, and it leaves them questioning their own reality. To help us unpack this, we're joined by Dr. Bryony Bamford, a clinical psychologist and founder and clinical director of the London Centre for Eating Disorders and Body Image. Bryony has worked extensively with individuals experiencing eating disorders, as well as with partners and families around them, supporting people through the fear, frustration, and helplessness that can come with it. Bryony, we're really glad you're here to help us discuss this topic.
We really are. Thank you so much for joining us
to be
for this.
here.
So we have, as Roz has just said, we've got a listener letter, which I will read out, and then Bryony's going to help us talk about this and talk about eating disorders in general, how they can show up, the risk factors for developing an eating disorder, and also what can be done to help. So here goes with the letter. Dear therapists, I need your help with what to do. My partner barely eats. She stopped eating carbs. Her portions are tiny. She counts calories, weighs food, and also runs a lot. When I try to point it out, I'm the problem. She says she's fine, that she's just being healthy, and I need to stop worrying. I start questioning myself, like maybe I'm overreacting, but deep down I know I'm not. I can see what's happening. It's very clear it's becoming a serious problem, and she's lost a lot of weight. Everything around food feels tense now. Every meal feels loaded. I'm constantly thinking about what she's eating or not, whether I should say something or keep quiet. If I do say something, it turns into defensiveness or she shuts down. If I don't, I feel like I'm just standing by while things get worse. I think the denial is the hardest part. I don't know how to help someone who genuinely doesn't think anything is wrong. There's nothing I can do. Should I keep pushing back? Should I back off, say something, say nothing? Every option feels wrong. People tell me she needs to hit rock bottom before she recognizes the problem. But I'm scared that by then it'll be too late for us and maybe even for her. I just need to understand what I'm supposed to do when the person who needs help doesn't believe they need it. Wow.
Powerful.
It sounds tough, doesn't it? Really tough for them.
Yeah. And really worth saying, I think, that what's described there in that letter is a really, really common experience for people who, friends and families and loved ones of people who are struggling with an eating disorder. So a lot of what is said there is very, very common.
Mm-hmm. Yeah, that denial part can be so hard, can't it, for loved ones of any kind of addiction or problem.
Yes. Well, I think, and we think about eating disorders. Eating disorders are one of the only mental health conditions, and they are mental health conditions, where denial of the seriousness of the illness, denial of the impact of the illness is part of the core diagnostic criteria. So they're really different from a lot of other mental health conditions, where the very fact that people don't understand or don't have full insight into the seriousness and the impact is part of what makes it an eating disorder, certainly in the case of anorexia.
So it's almost like you're going to always get that in some respects, that for the people who sort of are around, the loved ones,
Yes.
aren't necessarily going to understand and are going to
It's-
feel in a way like this listener.
Yeah, absolutely, absolutely. That it's central to part of having an eating disorder, that it's minimized or not seen as a difficulty. I think the other part that's important here is eating disorders are also quite distinct from other mental health conditions in that they're often functional for the person who is struggling with them. So we describe them as ego-syntonic. What that means is they're wanted in some way. So if you think about other mental health conditions, you don't usually encounter people saying, I really want to keep my depression, or I really, really want to keep my phobia or my anxiety disorder. But with eating disorders, you do. You see people who are incredibly scared of giving up certain aspects of their eating disorder, or who really value aspects of their eating disorder. And that's because certainly at the start of an eating disorder, those behaviors have some felt benefit or some function. Now that function will be different person to person, but it's common to eating disorders that they're valued, they're wanted. So what that means is that you get people who are often really struggling with a very, very serious illness. And let's remember that, eating disorders are dangerous. They're dangerous illnesses physically as well as psychologically. So they have the highest mortality rate of any of the mental health illnesses. So you get what is a very, very serious, very impactful disorder paired with this valuing of it, this desire to keep it, and this lack of insight, lack of awareness into the seriousness of it. And of course, when you look at it like that, of course, it's confusing and scary and very easy to sort of misunderstand, I guess, or not know how to help as a family member.
Yeah, I mean, I'm sure there's a lot of helplessness that comes with it, isn't there? Because like you say, with that sort of dichotomy almost for the person, that there's this function, this strategy that they're, and valuing it in one way and yet actually at risk in another. And then those around them not necessarily knowing what to do or not understanding and feeling so helpless. It must create so many tensions in relationships, I imagine.
Yeah, absolutely. Because, let's not forget that food punctuates our everyday, multiple times a day.
And it's survival.
Absolutely. It's integral to survival. And it might be helpful to think a little bit about the impact on the brain when the brain becomes starved. So people become extremely rigid. They become extremely obsessional. The anxiety increases, isolation increases. So personalities change quite significantly when the brain becomes starved. And family members will be the people that witness that. They will be seeing the distress that is present around meal times every multiple times a day, as we said. So it's really quite frightening, I think, as a family member to witness. But we're also not automatically, born knowing how to help someone with an eating disorder. They're really difficult illnesses to understand. There are many misconceptions about what eating disorders are, not least that people sort of think that they're about vanity, about a desire to just eat more healthily or just to change weight, rather than recognizing the mental health aspect of eating disorders. So, of course, people don't necessarily automatically know how to help or how to support people.
Yeah, just
Nah.
sorry, Bryony, just wanted to go back a little bit to what you said about the function. And I was just thinking there about culturally and with social media and this idea that a certain body shape, size, it's always been there. Maybe it's changed over the generations what that ideal is, but how that can play into it, that someone, if it's a restrictive one, they start losing weight and they get comments made. Oh, you're looking good. You're looking healthy. And how that can feed into it. Like you said, it's like it starts off and there might be some really, really important benefits to them.
Yeah. Yeah, absolutely. And eating disorders can start as relatively harmless, attempts to lose a little bit of weight or to be more healthy. Very, very few people, if any, start out with the intention of having a severe eating disorder. And certainly we live in a culture, we live in a society where there is a lot of talk around idealized body shapes, idealized body size and weight, and this idea that any body shape and size is achievable. We don't have similar
Mm,
conversations around height, do we?
mm,
Because we know that actually our height is genetically informed. Well, our weight is also predominantly genetically informed. Our
mm,
body shapes are predominantly genetically informed. So they're not things that we can change easily. But
mm.
the sort of the diet culture doesn't sell us that idea. It sells us an
No.
idea that any body size or any body shape is achievable. And the wellness movement, I think, also really sells us this idea that that restriction is healthy. It
Mm,
moralizes
mm,
food, doesn't it, into good foods and bad food,
mhm.
and what is the right way of eating.
Yeah.
Well, all of that, it doesn't cause an eating disorder in itself, but absolutely it heightens the risk of an eating
Yeah.
disorder.
Mhm.
Those people that are are predisposed to
And
developing.
where do you think is, that line in between an eating disorder and or healthy eating and an eating disorder? Where does that kind of come in?
Yeah, it's a really good question. There isn't as such a sort of a firm line in the sand. It's not quite as rigid as that. It's really about the degree of sort of how far it's taken, I suppose, the degree of rigidity. So most people who are eating healthily will also will have some level of flexibility around their eating.
Mhm.
And most people with an eating disorder will develop over time quite rigid rules around their eating. So
Mm.
flexibility lessens over time, but it's also very much about the meaning of deviation from that. So for someone with an eating disorder, if they deviate from a personally held food rule, the impact is quite significant emotionally and psychologically. So emotionally, there might be a lot of fear associated with breaking a food rule. What will this mean? What will happen? There might be a huge amount of guilt or shame associated with breaking a food rule. So emotionally, there's quite a significant impact um,
Mhm.
around eating in a sort of different way.
Mhm.
Equally, I think one of the things that really makes an eating disorder is the meaning that food and weight has to the individual. So we talk about over-evaluation of shape and weight, and that really is the idea that food and weight is used for self-evaluation. So it's seen as central to someone's self-worth, to their self-identity, um, to to the detriment of other aspects of self-identity. So if you think about um, most most humans, we will have a range of things that inform our self-worth. So we will value our careers, our friendships, our relationships, our families, aspects of our personality.
Mm.
And, we often sort of map that out as a pie chart. There will be multiple segments of that pie that help inform our self view and our identity. When someone has an eating disorder, if you were to draw the same pie chart, you see that food shape and weight starts to take up a much more significant
Mhm.
part of that pie.
Mm.
So it becomes the most important thing.
And if you think about that in terms of a relationship, like this person is talking about,
Mm,
that's going to have a massive impact, isn't
of
it? Because
course.
all those things that a relationship might involve, like hobbies,
Yeah,
eating out,
yeah, yeah, yeah.
time together, relaxation, the eating disorder can massively take over.
Yeah. The world becomes smaller, and
Mm.
things that were enjoyed previously as a couple
Yeah.
are deprioritized
Yeah.
as
Mhm.
food and shape becomes prioritized.
Yeah. I remember when I was going through my worst point of my eating, or one of my worst points, when I was younger, I was in a relationship
Mm.
and he ended up leaving me because he couldn't cope with it.
Mm.
And looking back, I totally understand it. How can someone at the age of 21 know how to cope with that? I didn't know how to cope with it, but yeah, it was, I get it.
Yeah.
Really hard for someone to be in a relationship with that.
Yes.
And also, when you were speaking earlier about, what happens to the brain as a result of it and the personality change.
Yeah.
So, that partner isn't going to necessarily know you as they knew you. It's going to be a change, isn't it, in how they understand you and relate to you. They're seeing something different and experiencing something different.
Absolutely. And eating disorders really thrive in isolation. They are disorders that isolate the sufferer. So people do lose friendships. They lose relationships. They, at their worst, that family relationships become really, really tense, really fractured. And that's one of the things, I think,
Yeah.
around for a family member is to be part of witnessing that impact.
Especially when you were, we were talking about, how food is a survival, and we're all aware of that we need to eat something. And so you can imagine that strain being huge, can't you, within a family or within a relationship, when you're just seeing somebody not doing that and so fearful of what might happen.
Yeah. It's survival, and it's also part of our sort of social lives, isn't it?
Yeah.
So going out for dinner, going out for drinks, cooking for each other, family meals. It's very much embedded within our society to center ourselves around food. And when people with an eating disorder start to find those experiences terrifying, when they can't go out for dinner because they don't know what's in the food, they don't know what's going to be on the menu, that they find food threatening. And so they start to pull away from enjoyable experiences around food. That has an impact as well.
What are your thoughts on the denial? Because that's probably, I think, one of the hardest things, isn't it, for someone watching on, when you can see it's happening, you can see it's getting worse, you're terrified of where that's going to go. You try and bring it up and it's met with defensiveness.
Yeah.
What are your thoughts on what someone can do when that's happening? Because it kind of leaves you with nothing, doesn't it?
Yeah. Yes. So the denial is really hard. I think it's worth understanding where the denial is coming from. So the denial, in part, is likely to come from a fear of change. So we talked about them eating disorders being functional illnesses, that they are valued. And often part of that denial is a fear of that being taken away. Part of that denial is likely to be feeling judged in some way. So we also talked about the way in which food and weight become central to someone's identity and their self-worth. And when someone comes along and says, I think something's wrong, I don't think you should be doing this, actually it can feel like a threat to your sense of self-worth.
Yeah.
So it can feel like you're being judged or criticized in some way. And we're all fairly defensive when we feel as though we're being judged or criticized. Way. I think also there's something around how slowly an eating disorder might sometimes develop, that, we don't notice changes in ourselves. It's a little bit like, you don't notice your children's height changing because you're with them every day. When you're living an eating disorder every day, it's not like you wake up one day and have a severe eating disorder. It's often little changes over time. So it can be hard to recognize those in yourself when you're not standing back and looking at, well, what was I like a year ago? What was food like a year ago. But also, as we said, in our culture, in our society, disordered eating has become quite normalized. It's become valued within our society, increasingly more and more so. There's a sense that, in order to be healthy, you have to be a certain weight. In order to be, that there's a right way of eating. So we're also asking people to slightly go against some of the cultural messages that they have been sold as truths.
Yeah.
So I think in addressing that denial, it can be helpful to understand where the denial is coming from. It's not seen as, as confusing or, so there isn't an argument around.
They're not just being difficult. There's a
Yeah,
there's a
absolutely.
fear there. There's probably a
Yeah,
reluctance to
absolutely.
want to even look at this.
And I think one of the least helpful things in a sense that can happen is to get into debate over how unwell someone is. So when that conversation becomes an argument, generally it's not going to feel like a helpful conversation on either.
The defensiveness is just going to get stronger.
Yes, absolutely, absolutely. So I suppose in terms of bringing it up, I would pick a time where there's enough time to have a conversation. I would prioritize trying to pick a calm time, not having these conversations when emotions are really heightened can be useful. And generally trying to share your own experience rather than what you're seeing. So I'm feeling really worried. I'm feeling really concerned. I'm really scared. Often picking up on the emotions is more helpful than picking up on the behavior.
Yeah.
So rather than going in with, you've lost weight, you're doing this, you're doing that, which can feel quite attacking, naming that you're feeling worried. And the reason you're feeling worried is because you love that person, you care about that person, and you feel as though they are becoming more isolated, more anxious, that there's something worrying them, that there's something troubling them. And often starting the conversation around the emotions rather than the behaviors is easier.
Really
And
good point.
I'd also highlight that it doesn't have to be one, long conversation. It can be multiple conversations. So if it feels as though the conversation isn't going in the direction that you want it to go, it's okay to stop and to say, actually, it feels like it's really hard for us to have a conversation about this right now. I know that it's really difficult for you to talk about this. Let's leave it there. But it feels important to me to come back to the conversation. So often it's multiple little conversations that help someone start to
Just sowing that seed.
Exactly. Sowing a seed. Yeah.
There's that, is it called the wheel of change or something, isn't it? Where there's pre-contemplation.
Yeah. Yes.
It might be helpful for us to put that in the show notes, actually. That
Yes.
before someone is ready for change, there's that other people are saying something.
Yes.
Before they even
So in
recognise it.
the wheel of change, we talk about pre-contemplation, contemplation, preparation, action, and people move throughout. That's the most important thing to recognize, that it isn't a circle that's sort of one directional. People move back and forth.
Yeah.
And that there, in terms of intervention and how you might help someone, it's important to recognize where they are in those stages of change and to meet them where they are. So forcing change, forcing someone into therapy or forcing change within therapy is never going to be.
Or giving ultimatums and things like that.
Absolutely. Yeah. But being curious.
So when do people come to you? At what stage in that would they be coming to you? Would they have already gone through that pre-contemplation element and then be coming to you?
Not always. They can come at any stage. Often if they're coming in a sort of pre-contemplation stage, it's because someone's asked them to.
Okay, so that might be a partner or a family member or whatever. Yeah.
And I wouldn't discourage that. I would encourage that. I think the other important thing to realize here is that family members don't know how to help. They can be an incredibly important part of treatment, and we can talk a little bit about the role that they might play in treatment.
Mm-hmm.
They can be integral to successful treatment and to recovery, but they
Right.
can't do that on their own.
Yeah.
This is an illness that needs specialist professional
Yeah.
support. But often I will say to people who are in the scenario, as is sort of set out in the listener letter, it might be around wondering with your loved one whether they would be prepared to do an assessment, just to meet with someone. You're not asking them to recover. You're not asking them to go into extensive, year-long treatment. You're just wondering whether they would be open to having a conversation with a professional. So we will often see people at that point who
Okay.
have agreed to an assessment, they've agreed to an initial meeting, and then we then have that conversation. We sort of, we're very used to having
Yeah.
conversations with people in that pre-contemplative stage and, exploring what are some of the things that you value. Is there anything that you do want to change? Is there anything that is worrying you? Are there any changes that you're aware of that are concerning to you? So we very much look at both sides at that
Yeah.
in order to help people to think about, could this be a problem? And we might then suggest something like, let's just do a brief piece of motivational work. So let's just spend some time together looking at this in detail in a safe space, in a space where you can be understood and the eating disorder can be understood, to decide whether this is something you want to do anything about. And if the answer is still no, that's okay. Maybe you need to go away and take a bit more time and come back when the time is right. So yes, we're very used to working with people at all stages.
I think that's really important, to giving someone the opportunity to recognize that there are things that it gives them. It's almost like then it's giving them permission to say, well, yeah, it's good. It's really good for this stuff.
Yeah.
And then they might feel more able to think about, this is the stuff that's not so great about it.
Yeah, it gets around the defensiveness in a
Yeah.
way. Very, very hard to name the things that aren't going so well if the things that you want to hold on to aren't recognised. Most medical conversations, so most conversations with with a GP or potentially with a non-ED medic or with family members, highlight the things that they want to change or that they think should change. Very few conversations until you're at the point where you come into specialist treatment will also consider, what is it doing for you?
Yeah.
Fears that you have around change. What are things that you value about what's going on for you at the moment? And it's only really by exploring that and thinking about whether there are any alternative ways of meeting those needs that people feel able to contemplate doing things differently.
So really feeling really understood, listened to, heard, having a safe space, not sort of, in a way, I'm hearing also that element of choice, that, if you're not ready to do this, go away, think about it.
Yeah.
And in terms of if it were a couple coming to you and you've got the partner, like with this listener letter, who's feeling so, doesn't understand how to support them, is always kind of up against somebody who doesn't believe they need the help. If they're coming in that dynamic to you, would you be seeing the person with an eating disorder kind of on their own first, to kind of build that sense that they're feeling heard and understood? And then how would you help the partner in that instance? How would you help this listener?
Yeah, there's a few different ways of doing it. And the answer to that will be sort of decided in part with, in that appointment.
Sure.
Absolutely. When someone has an eating disorder, they will need individual support. So that will need to be a part of the treatment. We're talking about adults. I'll talk about children
Yes.
potentially, because that's a slightly different, a different treatment situation. But with adults, change is often slow, and change is quite individualized. So there will need to be an individual element to that treatment. Now, there are some cases where there are difficulties in the relationship dynamic that are perpetuating an eating disorder. So conflict in a relationship or difficulties in a relationship may need to be addressed in order for the person to sort of feel as though they can change aspects of their eating disorder. So in those sorts of cases, then actually systemic work, couples therapy is something that we would recommend. Equally, we know that recovery doesn't happen in isolation. So therapy usually, not always, there are circumstances or situations where we might need to do more intensive forms of treatment. But therapy is usually once a week, maybe twice a week. And that is a huge number of hours outside of the therapy session where people are having to do really, really hard, scary things. And they are usually not doing those things in isolation. They are usually doing those things around partners or around family members. So sitting down and having to eat. And it's the family members that are there to support them in those moments. So it's really important that the family member understands what their role is. And that might be done through psychoeducation, support in helping them to manage emotions when they come up, when their loved one is doing these scary things. It might also be done through supporting that family member. So witnessing your loved one do hard things and go through huge levels of distress is distressing. Playing a support role, being a carer, is hard work. It's really hard work. And actually, there was a really lovely piece of research done fairly recently that showed quite high levels of PTSD in people who had supported family members through an eating disorder. So it's also traumatizing.
Yeah, that
And
makes
support,
sense.
support for those family members is key. There's different ways it can be done, and different things might be needed at different points of the recovery journey. But as a general rule, some sessions will need to involve both people in a couple. Some sessions will need to involve just the partner to give them support and ideas and guidance around supporting the person who's struggling. And sessions will also need to be done individually.
What if, things get really, really bad and the person is still not acknowledging it themselves, but they're getting increasingly ill and it's worrying physiologically, if we're talking about maybe a restrictive or binge purge type eating disorder, and that person is at risk, what can a loved one do then?
So at that point, I would probably be encouraging a loved one to take that person to seek medical guidance.
Right.
So that's another thing that makes eating disorders really quite unique from other mental health conditions, is there's a very real medical risk aspect around eating disorders, both restrictive eating disorders and binge purge eating disorders. Both have high mortality rates. So if a person really, really doesn't want to change, at a minimum, physical health needs to be monitored.
Right.
So presenting at a GP, and GPs can be hit and miss. You can get some incredible GPs who are really knowledgeable about eating disorders and really happy to do the medical monitoring. You can also get some GPs that don't quite understand eating disorders and don't always, unfortunately, say the most helpful things. But ensuring that medical monitoring, so bloods, ECG, blood pressure, etc., is done regularly to ensure that physical health is monitored, is at the levels of severity that you're talking about, is really important. If a GP is concerned about the level of medical risk, they will likely either refer to a consultant psychiatrist who is a specialist in eating disorders, who will really be able to interpret the medical results and think about treatment planning from that point. Or, sort of at the very, very severe end of the spectrum, a hospital admission might need to be arranged
Yeah.
in order to
Yeah.
medically stabilize somebody.
That's really hard, isn't it? Really painful for
It's
people.
really, it's really, really hard because at that point, treatment is life-saving,
Yeah.
not necessarily psychological.
Yeah.
That I would argue that treatment always needs to have psychology as part of it. There
Mm.
was more historically, I think there was an argument that when people are highly medically compromised and very cognitively compromised, that they can't benefit from psychology. I think people can always benefit from psychology, from feeling understood and for
Yeah.
developing an awareness of what's going on for them. Um, but at the severe end of the spectrum, it's really, really important that medics are involved as
Mhm.
well. It's often
Mhm.
terrifying for people. It becomes incredibly hard at that
Mhm.
end of the severity spectrum.
Do you tend to see mostly bulimia and anorexia?
No, we see all forms of eating disorders.
Okay.
Um, so anyone, I think one of the important things for me in developing the service and in thinking about what I want the service to be is that it is a service that doesn't have boundaries as such. It doesn't have criteria. So a lot of the NHS services, and I can understand why, because of course there's resource issues attached
Money.
to services,
Mm.
absolutely, will have really quite rigid criteria over who they will accept.
Mm.
And there's a hugely important movement called Dump the Scales, which talks about the importance of access, equal access to treatment, not being dependent on how much you weigh. It's
Yeah.
such an unhelpful message. You're not ill enough to seek treatment. And what do people do then? They go
Lose
away
weight.
and they become ill enough.
Yeah.
And what's worse is they also have a negative experience of treatment.
Well, I
Um,
remember being told that when I was young, that I was at a healthy weight, and that was a trigger for me because I was like, oh, well, I must need to lose weight then.
yeah. And we talk about the denial. And when the message that is given to you by an expert is you're not done well enough, well, you're just reinforcing that
Mm.
denial and that lack of awareness. So it's an incredibly unhelpful message, and I would love to see it change. The only reason it is there is because of money, of course.
Mm.
But I am lucky enough to be in a position where in private services you don't have to have those criteria. So it was very important to me to develop a service that would see anyone that wanted to change any aspect of their relationship with food, self, or body.
Okay. Yeah. So say a little bit more about bulimia nervosa, because we've kind of implied this is more around restrictive.
Yes, yes, we have. And bulimia, I think it's important to say that, we categorize into anorexia and bulimia, but the reality is that there's much more fluidity between
Mm.
diagnostic categories.
Mm.
So most people will move between diagnostic categories at different points of their life. Bulimia is similar to anorexia in that what's central to bulimia is an over-evaluation of shape and weight. So shape and weight becomes integral to someone's self-identity. It's different from anorexia in that it involves episodes of binging and attempts to compensate for that binge. Now, we talked earlier a little bit about some of the changes in brain functioning when you become. So, in anorexia, you become more rigid, you become more obsessional, you become more rules based, you become more anxious, and that really perpetuates or maintains the anorexia.
Mm.
One of the other really important things that happens when you become starved is you start to crave food.
Mm.
So if you think about it in terms of drinking, if it's a very, very hot day, you forgot your water bottle, you don't have access to to a shop to buy a drink, you become increasingly thirsty. You start to become quite preoccupied with thinking about that thirst. We're
Yeah.
thinking about when can I get a drink? And when you do then have access to water or to fluid, you don't tend to take a little sip and then feel satisfied and put it back down. You tend to
Gulp it.
Gulp it down. No, to pick up the largest glass that you can see and drink as much fluid as you can to quench that thirst. Now, the same thing happens with food. When you are hungry, when you are banning yourself from having foods that the body needs or enjoys, you start to become preoccupied with thinking about food.
Does that work the same for if people are restricting a certain type of food, like they're not having carbs, that they then will crave?
Yeah,
think
absolutely.
about carb-laden foods.
I mean, we need carbs. There's some incredibly unhelpful diet messages about, that demonize carbs, but carbs are essential to our healthy functioning as human beings. We need all food groups.
Yeah.
And carbs also are our best source of energy. So they sort of stave off hunger for longest, if you like. So carbs are essential, but any food group that is needed or is enjoyed, if you're someone that really enjoys chocolate and you ban yourself rigidly from having any chocolate, then the brain will start to think about what it wants and you will start to experience cravings for chocolate. So when you then have access to foods, similarly as we were talking about with fluids, you don't just tend to have a small amount of a healthy snack and feel satisfied and stop there. You tend to gulp food. You tend to binge food. And what is often under-recognized in bulimia is the impact of restriction on binging, that the restriction contributes to the craving around food, to the binging. Now, of course, that's not the whole story. Emotions play a very significant part as well. But what most people don't recognize is that changing the binge is not about willpower. It's not about deciding to do things differently. It's about recognizing that usually restriction is a part of that they need to fuel their body adequately and appropriately to reduce the physiological cravings towards binging.
It's incredible, isn't it? I've worked with clients and with binge purging and the restrictive part. Once we address the restriction, very often the binging stops or drastically reduces.
Yes, but that's of course the scary part. That's the part that most people don't want to do. Most people want to stop the binging, but not the restriction. So again, similarly, as we were saying with anorexia, that you need to do a motivational piece of work, that you need to help people become less fearful of changing their eating habits. With bulimia, you're doing exactly the same thing. You're helping people become less fearful of changing the restriction in order that the binging stops. And absolutely, as you say, when you're able to do that, binging vastly reduces. And what's left over, it tends to be the emotional binges. It tends to be binges that are triggered by...
And then you know what you're addressing with that.
Absolutely. Because if you're binging, daily, multiple times a day, potentially, physiologically, it's really hard to unpick which of these binges are emotionally triggered.
Yeah.
You need to sort of stop the physiological binges, if you like, in order to have the information that you need around the emotional.
I think the other misconception people have about bulimia is that it's always about vomiting.
Yes.
And it's not, is it? It
No,
can be any
absolutely
kind
not.
of compensation.
No, absolutely not. Yeah, you're right. That's a common stereotype, is that to meet criteria for bulimia, you have to binge and then you have to self-induce vomiting. But actually, in the criteria for bulimia, it is any attempt to compensate for a binge. That can be excessive exercise. That can be laxative use. That can also be more restriction, further extreme restriction. So if you are someone who restricts and then binges and then starves themselves as a sort of response to or a compensation for that binge, you will absolutely still meet criteria for binging.
Right.
For bulimia.
Yeah. Okay. So, Bryony, does treatment for an eating disorder look any different for a young person or child? Let's say a parent is listening to this and their child is is struggling?
Good question. And in short, yes, it does. So within the field of eating disorders, we have treatments that have been specifically developed to treat eating disorders. It's worth saying that we don't have a treatment that is successful with everybody, but we have treatments that we know are more effective at treating eating disorders. So things like CBTE, mantra. With children, the interventions with the greatest evidence base are family-based interventions. So FBT or FTAN, FBTN. So interventions with young people involve family members. We know that parents, that carers and family members are crucial to successful treatment of an eating disorder for a young person. And the reason for that is, when I was talking earlier about recovery needing to involve doing hard things and how hard that can be, asking a child to do a hard thing in isolation is never going to work. Asking a child to do something that is going to send their anxiety higher, that they don't want to do, that they are really terrified of doing, doesn't work unless you've got family support to help them do that.
Right.
So in the vast majority of cases, certainly initially, interventions, treatment for younger people will involve family members.
Right.
I would also say that there's a slight difference in how urgently we might treat with a child. So when I was talking earlier about the importance of increasing motivation and taking time and letting people know that they can go away, take some time and come back when they're ready, we don't tend to do that with children. Certainly we wouldn't do that if the eating disorder was quite severe. We know that earlier intervention provides the best chance of recovery. We know that in children, restriction and eating disordered behaviours are really, really dangerous. So we won't tend to ever recommend that someone go away and come back when they're ready.
That's a really important distinction, isn't it?
It's a really important distinction, yeah. What we will do is we will use the family to help support change.
What I'll add to that, though, is unfortunately this does happen with the NHS.
Yes, it does.
It does. I hear it all the time. And it's just so frustrating. I know there's limitations. I know, I get that.
Yes.
It's just very scary, isn't it?
Yeah. It's terrifying. And yes, it does happen. And believe me, no one in those eating disorder services, none of the clinicians,
they don't want
that to be the case.
No.
We know, we have huge amounts of evidence that delaying treatment, that's turning people away from treatment, is unhelpful.
Yeah.
Actively unhelpful. Nobody wants to be in that position. But sadly, the resources are not adequate to treat everybody with an eating disorder. There just isn't the funding given to eating disorder services that enables them to treat what is, really quite a prevalent disorder. And that's the other part of the picture here, is that eating disorders are on the rise. They are increasing. We are seeing more young people presenting to services with eating disorders. Funding is decreasing.
Yeah.
We can't treat, NHS services can't treat everyone. And it's a huge problem because private services are expensive. When you're needing to involve a medic and a dietitian and potentially have psychology a couple of times a week, because that's what's needed to create change, it becomes expensive. And so, yes, it's a huge problem. It's a huge problem that people are turned
And do
away.
you have any advice for those people who can't afford the private service and are in that desperate state, what they would do?
Fight. I think, keep fighting and keep presenting. I think there are some incredible books and resources around there for parents. So it's worth researching family-based treatment. Eva Musby has some fantastic resources on her website aimed at parents. There are some wonderful books that can help guide parents through how to support a child with an eating disorder. In an ideal world, of course, you'd have professional help supporting you to do in the absence of professional help, I would look into family-based treatment or family therapy for anorexia nervosa. Do as much reading as you can, watch the resources, and try to create change at home as best you can whilst fighting.
Mm-hmm.
Yeah. Can I add in that to me, it feels really important that if someone is going privately, that they are finding someone who really understands eating disorders.
Yes, absolutely.
Not just,
Absolutely.
I don't want to, I don't know, but not just a counsellor who's done a bit of reading or.
Yeah, I'm really glad you said that, because honestly, that's one of my biggest bugbears. The number of people that we see come to us having tried multiple
Yeah.
counsellors or therapists before that weren't specialists in eating disorders.
Mm-hmm.
And therapy can do harm. Treatment
Yeah.
can do harm when it's not the right treatment.
Yeah.
Yeah.
And messages can be unhelpful, or or food can just be ignored and people can be talking about absolutely the wrong thing. So, yes, I mean, this is something I talk about a huge amount, but if you are struggling with an eating disorder, access to the right support, to specialist support, talking to someone who really understands eating disorders, how they develop, why
Yeah.
they develop, how they are maintained is crucial. It's really important. I can't say.
There's a list of therapists trained in CBT on the CBTE website, isn't there?
There is, yes, there is. Yes, generally, I would look out for if you see someone's bio and it talks about what they specialize in or what they treat, and you've got a long list of disorders.
Mm-hmm.
Generally, they're not going to be an expert or a specialist in eating disorders. That people who specialize in eating disorders tend to treat eating disorders, and it is worth seeking that
Yeah.
specialist support. So that's
Mm.
one of my main tips, I suppose, is just, if you're contacting someone and they say, oh yes, I see eating disorders, but I also see 10 other presentations, they won't be an expert.
Yeah. So we can put that, Ali, you were saying about the CBT list. So we could put that again, couldn't we, onto the show notes? And I know, Bryony, you were mentioning another website. Perhaps you could let us know that, and maybe some essential books that we could put on. Or if one of those websites has those or yours has those, then, we maybe don't need to do the books. But it would be really helpful. I think the more we can give people and resources, the better.
Yeah, I can do that. I can send something across.
So I'm wondering whether, I'm just noticing the time, and I'm wondering whether it's been so interesting listening and talking with you, Bryony, and I think that there'd be such useful things to hear for our listeners. And I'm just wondering if there maybe we do a sort of 3 takeaway tips to leave our listeners with something to help them. So bearing in mind our listener letter, and the fact that they're sort of really struggling to know what to do, are there perhaps 3 tips you could leave us with for this person to get some help?
3 top takeaway tips.
Yes, absolutely. Absolutely. I mean, of course, there's many, many, many tips that I could give, but thinking about what might be most useful to the listener. I think firstly, recognizing that partners can need support too, that they that what they're going through can be really distressing for them, and that supporting someone through recovery can be really, really hard work, and not to forget themselves.
Mm.
That support for themselves, they're often the people that sort of get deprioritized or missed off the list, but actually support and education for them can be really important in helping a person to recover from an eating disorder. I think challenging that misconception that eating disorders are just about weight or just about aesthetics. I think it's really important to recognize that they're mental health conditions, that the eating or the weight is it's the tip of the iceberg, if you like, the bit that you see, but it's the response to what's going on underneath. And that's the bit that you often don't see. So that will be the psychological, emotional difficulties that someone is experiencing that they are using food or they are using weight to control or to mask or to respond to in some way. So recognizing that talking just about food and weight isn't helpful, I think, is key. We often see families get really caught up in this quite problematic experience of just focusing on the weight, just focusing on the number. What's happening to the weight? Has it gone up? Has it gone down? And actually really forgetting that conversations just about the numbers really can become quite unhelpful. It perpetuates this idea that the only thing that's important here is the number. Recognizing what's going on underneath is key. And I think my third tip would be really recognizing that eating disorders are serious, that they are minimized, that they are perpetuated by a lot of unhelpful cultural messages, but they're risky disorders. They're disorders that at their worst kill people, but even if it doesn't get to that point, that have serious negative impacts on daily functioning, on emotions, on people's lives. So the family member, the partner may be minimizing. That doesn't mean that you should be minimizing too. It's okay to be concerned, and it's okay to express that concern.
They're all really useful tips.
Lots of compassion there for our listener. Yeah.
And I'm hearing all that sort of thread of feeling running through it all, which is so important, isn't it? Like you say, what's underneath.
Eating disorders are emotional disorders. The food is the mask. The food is the solution, if you like, to what is essentially an emotional disorder. So food is used to regulate emotion or to block emotion or to respond to emotion or to help people feel better about themselves because they're struggling with their self-worth or their self-esteem. It's those bits that need to be addressed, not just changing the food. Of course, changing the food is an important part of recovery because you can't change what's going on underneath unless you lift the lid. But it's incredibly important to what is underlying those food behaviours.
Yeah. So, Bryony, it's really helpful. If anybody wants to contact you, if something resonates for somebody having listened to this episode, can we put your details in our show notes so that people can get in touch with you?
Absolutely. I'll give you our website, and there's lots of information. The intention of the website is that it's also a resource. So there's information for parents, for carers, for partners, for sufferers, and resources embedded within the website. So absolutely, I'll pass that on.
Brilliant. Thank you so much.
There's so many more questions I've got. I wish we hadn't run out of time. There's so much I want to ask you, Bryony. But
so much more to say. They're and there's other eating disorders that we haven't even touched on.
Yes,
as well.
Of course.
So always a long conversation to have around.
Thank you so much. It's been an absolute pleasure.
Yes,
thank you for inviting me.
And if everybody can remember to follow, like, subscribe, and it helps us get this out to other people. And as we've said, if anything resonates in this episode, then look in our show notes and you'll find the link to Bryony's website. Thank you. Thanks, Bryony.
Thank you.